Okay, so we're going to complete the urinary system, and this is primarily all physiology in this section. Primarily, toward the end, we talk, well, that's physiology too. We talk about a lot about urinalysis. So let me put this in slideshow mode. Okay. All right, so we talked a lot about structure function of the urinary system, the different organs, the kidneys, cortex versus medulla, the mechanism of transporting urine from the kidneys to the bladder into the urethra. And now we're going to talk about some of the physiology or functions of the kidneys other than what we described before, how we maybe balance pH of blood, at the end of the system, how certain areas reabsorb 100% of amino acids and glucose if it can. And so now we're moving on to other aspects. So I mentioned before something called the juxtaglomerular apparatus. It is a junction of two structures together. It's either considered to be the beginning of the distal convoluted tubule or the end of the ascending loop of Henle, where the ascending loop of Henle becomes the the distal convoluted tubule. So depending on the book, some will refer to it as the DCT, others will say it's the distal portion of the ascending loop. But in any event, we're going to use DCT. So where the distal convoluted tubule, the wall of that tubule, abuts or is adjacent to the afferent arteriole. And that junction there is called the juxtaglomerular apparatus. There are two types of cells found there. The juxtaglomerular cells are in the afferent arteriole side. And those are the cells that release renin. So remember, and we're going to cover this again, that renin is part of the renin-angiotensin system. It is a hormone, an enzyme / hormone. So it makes sense because hormones use the bloodstream, is that the cells that produce the renin are going to be lining the afferent arteriole, so it goes right into the blood. The macula densa cells are a group of cells in the distal convoluted tubule. They detect they monitor the osmolality of the filtrate as it's passing through the duct system, because these cells are within the distal convoluted tubule, which is part of the nephron. So they're monitoring the contents of sodium chloride, that's passing through the nephron and the filtrate. So here's a picture of where they meet. We have the juxtaglomerular complex, they call it. We have the macula densa cells in the distal convoluted tubule, or the ascending loop of Henle, but most books say distal convoluted tubule. And where that is then adjacent to, you see these other kind of irregularly shaped cells of the afferent arteriole, where those two regions come together. Macula densa cells, juxtaglomerular cells. See, and if you look at the shape of those JG cells compared to the other, smooth muscle cells of the afferent arteriole, you'll see that they're, of a slightly different shape. So that's the juxtaglomerular apparatus. Here we have a slide. You can see that we have the Bowman's space, the Bowman's capsule, the glomerulus to the inside. We have a DCT there, and then just above it at about 2 o'clock, 3 o'clock is an afferent arteriole. So we're saying that junction there is the juxtaglomerular apparatus. All right, so juxtaglomerular apparatus helps regulate what's called glomerular filtration rate. Glomerular filtration rate is the amount of filtrate formed in both kidneys per minute. And it should stay about a constant homeostatic rate of about 125 milliliters per minute. All right, that's the goal. It can go a little higher, a little lower, but you want to be about a fairly consistent 125 milliliters per minute. So that is a product of blood pressure and the amount of filtrate, the neurological input to how much blood is being transported to the kidneys. All right, so when glomerular filtration rate is high, I'm going to give you a scenario of what that means. When its glomerular filtration rate is high, the fluid is passing through the tubular system very rapidly. Right? So picture a conveyor belt traveling from the renal corpuscle through the PCT descending, ascending loops of Henle, distal convoluted tubule, and out. All right. And that conveyor belt should be moving at a particular speed, to produce about 125 milliliters per minute of filtrate. All right. Okay. If the conveyor belt is moving quickly, you don't have enough time to reabsorb as much water and sodium chloride as you might want. So it ends up staying in the filtrate, going out as urine, and being eliminated from the body. So when when GFR is high, there's not enough time to reabsorb water and ions. It's like a fast conveyor belt. Thus, we have increased fluid loss and increased ions in filtrate, and ultimately, goes out in urine. When the glomerular filtration rate is lower than normal, you have the opportunity now to reabsorb more than maybe you should, more water and more ions. It's a slow conveyor belt. So essentially you kind of pick it dry of, so much of the material there. Thus, you have increased water absorption and ion absorption, less going out in urine. So, it kind of depends on, whether you're trying to adjust your glomerular filtration rate from being lower to higher. If it's been too high, you're trying to slow it down, but, we're just trying to describe the scenario. If GFR stays high too long, then we don't have enough time to reabsorb water. You start to get dehydrated. You lose a lot of that sodium chloride, and you end up finding it in urine when you test urine later. If it's too low, then we absorb maybe too much fluid, too much sodium chloride, and now your urine is very concentrated, and you have increased maybe blood volume and blood pressure too much. Okay, so factors affecting glomerular filtration rate. Glomerular filtration rate is directly dependent on blood pressure and blood flow. And both of those things, can have both internal, what's called internal sources of control of the kidneys, and then outside of the kidneys, like your whole nervous system, like the autonomic nervous system. If blood pressure is too high, right, blood flow is high, as in, dilated arterioles, because they'll let more blood, pass through and through that afferent arteriole into the glomerular capillaries. Thus, glomerular filtration rate is increasing. That conveyor belt now is traveling pretty fast. Right? So filtrate flows too fast, water and other solutes are not absorbed. So what happens? We have water loss is increased. Therefore, blood volume decreases, and so does blood pressure. If blood pressure is too low, where blood flow is low, as in a constricted afferent arteriole, then the GFR decreases. Right, so now we have a slow moving conveyor belt, fluid moving slowly through the nephron. Right, filtrate flows too slow. Water and other solutes are reabsorbed in greater amounts. Sorry, that blue arrow is a little high. And that then produces water loss decreases, which means water absorption increases. Right? So that translates into increased blood volume and blood pressure. GFR must be regulated to remain constant for homeostasis. So we have three mechanisms that can affect glomerular filtration. We have what's called renal intrinsic mechanisms. Those are the mechanisms within the kidney itself. We're going to talk about that. Hormonal influence, which is, is stimulated from outside of the kidneys. I mean, it will eventually affect the kidneys because that's where GFR is occurring. But, the stimulus for some kind of change is outside the kidneys. And neural mechanisms like the sympathetic nervous system, that is, again, outside of the kidney. It ends up targeting the kidney, but the stimulus is from outside the kidney. Okay, so let's look at kind of briefly the renal / intrinsic regulation of GFR. The primary goal is just to maintain a constant homeostatic GFR. And this is the kind of mechanisms that will dominate generally as you're just sitting still, you're sitting in a classroom, or you're watching TV. Is that there's no particular other outside source or stimulus like the sympathetic nervous system. These are the local mechanisms. This job is just to maintain about that 125 milliliters, of per minute of filtration. Okay, so we had the myogenic mechanism. Essentially, it's a stretch mechanism, a stretch reflex. The smooth muscle of arterioles, gets stretched because, let's say blood pressure is too high, right? And when they get stretched, they rebound back a little bit to slow down and kind of offset the pressure that's pushing against their blood vessel walls. Once they get stretched a little bit like a rubber band, they're going to kind of bounce back again. And thus they vasoconstrict, which then decreases the GFR back to a normal rate. When glomerular filtration rate or blood pressure is too low, then those blood vessels have a tendency to just dilate some and let more blood pass through there and increase the flow through there. All right, so it's generally this myogenic, meaning muscle mechanism, is if the blood vessel stretches a little bit, then it kind of rebounds back again. Kind of like Frank Sterling's law of the heart. You stretch it, it contracts back again. Okay, but we also have what's called the tubuloglomerular feedback mechanism. And this is the influence of those maculodensa cells in the distal convoluted tubule. So as blood pressure increases, right, and we have an increased glomerular filtration rate because the filtrate's going to be moving faster, a fast moving conveyor belt, those maculodensa cells start to detect an increase of the sodium and potassium in the filtrate because it's moving so fast, we're not reabsorbing it and putting it in blood. All right. So moving so fast, you cannot resorb in time and provide feedback. So they provide feedback to the afferent arterioles. If GFR is too fast, maculodensa cells can release vasoconstrictor chemicals like nitric oxide, and thus vasoconstrict that afferent arteriole next door and decrease the flow to get your GFR to decrease a little bit and slow down. Right? If the GFR, the blood pressure is too slow, then the maculodensa cells will allow vasodilation to increase the glomerular filtration rate. So you not only have this stretch response of the smooth muscle, in the afferent arteriole, but you have a certain amount of input to that from the maculodensa cells in the distal convoluted tubule portion of the structure. All right, but then we have extrinsic regulation. Right, so in extrinsic regulation, we start looking at those hormones we looked at. Now, really, all four hormones of blood pressure and blood volume and blood pressure. We have the renin-angiotensin mechanism, which we were just kind of describing before. Primary goal here, when the source is extrinsic to the kidney, is to maintain appropriate systemic blood pressure. That now takes precedence over maintaining a nice homeostatic, steady glomerular filtration rate. Right now, it's like, look, what takes precedence over that? I mean, it's very nice to maintaining GFR in that nice normal homeostatic normal range, but when all over blood pressure, systemic blood pressure is becoming at risk, that takes priority. That needs to be altered, or managed first. So that takes precedence. So let's say we have a hemorrhage or severe dehydration. We have low blood volume, low blood pressure, right? This will cause the release of renin, which then directly causes water absorption. As you know, renin will convert, go through the conversion process of angiotensinogen to angiotensin 1. And then we have to convert angiotensin 1 to angiotensin 2. And thus it very strongly starts to increase blood volume and blood pressure and will cause vasoconstriction to increase blood pressure. Remember, we also have atrial natriuretic peptide that works in reverse when the blood pressure is too high, right? And the atria of the heart is going to secrete atrial natriuretic peptide, which then has the opposite effect. It blocks antidiuretic, it blocks aldosterone, it blocks or inhibits renin, so that your kidneys have a chance to catch up and capture all that excess fluid, let it, because it's going to, you're going to have increased, with this increased blood pressure, it increases the glomerular filtration rate, which means the fluid is passing through the nephron quickly. You don't have as much time to reabsorb water and electrolytes, and you let it now on purpose now. I mean, you want this now, just spill over and produce urine, pass it to the bladder and eliminate from the body. And now the blood volume and the blood pressure decreases. So again, as a review now for about the third, maybe fourth time, hormonal regulation, blood volume and blood pressure. Remember that the first three here in red are hormones used when we have higher, when we need, we have high low blood pressure that need, and I can't say this now, low blood volume, low blood pressure, and how we increase blood volume and therefore blood pressure. That is antidiuretic, aldosterone, and renin-angiotensin. And then the only one that's secreted when you have higher than normal blood pressure and blood volume, thus ending with lower blood volume and blood pressure, will be the one in blue, atrial natriuretic peptide. Okay, so remember, antidiuretic hormone targets the kidneys, produced in the anterior pituitary. I'm sorry, I am just having quite a time today. Stored and released from the posterior pituitary along with oxytocin there. Antidiuretic is a very potent hormone to reabsorb the majority of water that is passing through the kidneys. So it very strongly reabsorbs water. It also stimulates the thirst center so that you start taking in more fluid. And thus it acts to increase water absorption, increase blood volume, and therefore blood pressure. Okay, then we have aldosterone from the adrenal cortex. And it also translates into increasing blood volume and blood pressure, but it uses another mechanism, right? It stimulates the active transport, reabsorption of sodium. Chloride follows it. Thus, water follows as well, because where salt goes, water goes. But, as a consequence of absorbing sodium, we need to secrete one potassium. And then we have our renin-angiotensin. So remember, looking at this image, right? The renin is coming from the kidney. The liver produces angiotensinogen. These compounds that end in OGEN are inactive forms. They're there ready to go when you need them. So when you do need it, the kidney secretes the renin into the bloodstream, comes from the afferent arteriole, those juxtaglomerular cells, enters into the bloodstream and converts angiotensinogen to angiotensin 1. And then ACE, angiotensin converting enzyme from the lungs, will convert angiotensin 1 to angiotensin 2. That's the potent form. That's the big vasoconstrictor. It helps stimulate further secretion of aldosterone, antidiuretic. It stimulates the thirst center. But this is the only hormone that will stimulate vasoconstriction. So it's a pretty powerful hormone. All right, then we have the influence of the sympathetic nervous system. Remember that when you're in fight or flight mode, you need to increase blood volume and therefore blood pressure. You generally vasoconstrict to, most blood vessels because you need to overall increase systemic blood pressure, but you will, vasodilate to the organs that need to have blood circulating to them, like skeletal muscle and to the heart and to the lungs. So the release of epinephrine constricts the afferent arteriole. And it slows down the glomerular filtration rate. So look, if we constrict the afferent arteriole, we slow down the blood flow into the renal corpuscle. Therefore, that translates into a slower moving conveyor belt through that nephron. So the slower filtrate rate allows more sodium and more water to be reabsorbed, therefore increasing blood volume and blood pressure. It also stimulates the JG cells to release renin to further increase blood pressure. So this chart is pretty handy. I love things that are color coded. You just have to kind of work your way through each column. But what I do is, I think it makes more sense is to, of course, read the top in pink. It says you have a decreased systemic blood pressure. So, this could be the opposite that said increased systemic blood pressure, and you'd see different responses here. But they're going to use the example of decreased systemic blood pressure. All right. And then read in the bottom, because that tells you what it means to be in the blue column, that kind of orangey column, the green column, and I guess that's just green, over to the right-hand side. Right. So the blue column and that first orangey column, all right, we have the myogenic mechanism and the tubuloglomerular mechanism. Blah, it's a lot to say. All right, and then look below that. Those are the two components of intrinsic mechanisms. Right, intrinsic mechanisms directly regulate GFR despite moderate changes in blood pressure between 80 to 180 millimeters of mercury of arterial pressure. So what it's saying is that, its goal is just to maintain a normal GFR, a homeostatic GFR rate, despite small changes in blood pressure. Right? But then to the right, you have two sources in green and cream there. Those are your extrinsic mechanisms. They indirectly regulate GFR by maintaining systemic blood pressure, which drives filtration rate in the kidneys. Right? So the goal of the intrinsic mechanism is just merely to stabilize the GFR. Right? When you don't really have a whole lot other things going on in the body. But when you are in, let's say, sympathetic mode, or you have extreme dehydration or blood loss where your systemic blood pressure is suffering, then you see these other mechanisms kick in. And so it kind of tells you, okay, when needed, systemic blood pressure takes priority over, the homeostatic GFR. We're going to use glomerular filtration rate and modulate it, increase it maybe higher than normal or lower than normal to balance and restore appropriate systemic blood pressure. If you understand that concept, then you'll be in good shape. Okay, regulation of urine concentration and volume. This is regulated by hormones at the distal convoluted tubuline collecting ducts. Remember when we looked at the chart, that we identified the three processes of forming urine. We had filtration, reabsorption, and secretion. We said at the end of the system, at the DCT and collecting duct, we have two major things going on: balance blood volume, blood pressure, and to also balance blood pH, as well as parathyroid hormone targets it to increase calcium absorption if necessary. Okay, so dilute urine, right? But to have dilute urine, it means that you have all the same waste products, the material you want to eliminate from blood is being eliminated from the body, but you either have that same quantity either in a quarter of a cup of water or a gallon of water. When it's released in a gallon of water, those substances are dilute. It's spread out amongst a high water volume. So excess water creates low blood osmolality, very dilute urine. If less antidiuretic hormone is released, the collecting ducts are impermeable to water and increases urine volume and output. Right. So what does that mean? Right. To have dilute urine, it means you're not secreting a lot of the antidiuretic aldosterone, renin-angiotensin. Right? So as you secrete less and less antidiuretic hormone, because your blood pressure is normal, right? Your blood volume is normal. It allows that the excess fluid that's circulating your body because you just drank a gallon of water, maybe, now overflows, right? The glomerular filtration rate will be rather rapid, and it's going to flow right through the tubule system and out in the ureters and down to the bladder, and out you go. Right? So if you are fully hydrated and you have appropriate blood pressure, then you don't need to be reabsorbing all this water. You're just going to let it flow out. Right? Or you can have concentrated urine, which means you're still getting rid of the same amount of solute, waste product, but it's maybe in just a small quantity of water. Right? So that creates a high osmolality environment. So when we have high osmolality in blood, it stimulates antidiuretic to be released. Right? So you have generally low blood volume, low blood pressure, your blood is concentrated, right? It might not be, 55% plasma, maybe it's only 50% plasma and 50% formed element now. That's what they mean by high osmolality in blood. So when that happens, it tells the brain, okay, we need to start reabsorbing some fluid. So now we secrete more antidiuretic. Remember, it targets the kidneys. It increases the permeability, opens up those aquaporins so that water flows from in the tubular system of the nephron to the interstitial space into the blood. And now we increase water absorption to increase blood volume and blood pressure, but the amount of urine we produce decreases and it becomes more concentrated. So the collecting ducts of the nephron are naturally impermeable to water, right? You have to have hormones being secreted for the water to go from inside that nephron, maximum into the bloodstream. Otherwise it generally doesn't leak out. Right? You have to start actively, opening up those aquaporins, to let the water travel from, within the nephron into the cardiovascular system. Right? That's why, when you drink a gallon of water, you don't have to have, an extra hormone, except if your blood pressure goes really, really high. All right, then atrial natriuretic peptide is going to be secreted. But generally, if you have a normal hydration rate, the fluid you take in, by drinking fluids or the fluid component of foods, what you take in is what you're going to eliminate. If you're of a normal hydration level, all right, and you don't need to be storing anymore, then the fluids are going to kind of circulate through your body, through the interstitial spaces, be picked up the lymphatic system, travel to the kidneys. It'll eventually circulate through the kidneys and the excess is eliminated as urine. You don't have to do anything extraordinary for that to happen. But if you do want to start reabsorbing water, then you're going to have to use antidiuretic. Generally, that's the one that's first and most potent. Then aldosterone, and then renin-angiotensin, because it's the only one that will vasoconstrict. If it's really high, then you're going to release atrial natriuretic peptide. But there's a lot of wiggle room within there. All right, so knowing what you know now about hormones, what would you release if you wanted to concentrate your urine and preserve body water? Well, that would be the first hormones in red: antidiuretic, aldosterone, and renin. What would you do if you wanted to dilute urine? Like what hormone? It would be the opposite, the one in blue, atrial natriuretic peptide. And what effect does caffeine and alcohol have on urine output? Well, I think most of you know that it increases your urine output. Why? Because it either will inhibit antidiuretic hormone from being released, from where it's stored in the posterior pituitary, or, it will affect certain aquaporins and things in regions of the nephron, so that the fluid that's passing into the nephron does not get reabsorbed. It just travels through, travels through the renal pelvis, down the ureters, down the bladder, and up you go. Okay, so let's talk about renal plasma threshold, because this is a really good concept for you to understand as well. If blood glucose level exceeds the PCT's, the proximal convoluted tubules' ability to absorb 100%, you will get spillover into urine. All right, so what do we mean by that? Normal fasting glucose level. So you stop eating any foods and for about 8 to 10 hours, and then you want to see, what are my glucose levels in blood? It should be about 70 to 100, 110 milligrams per deciliter. Your insulin and glucagon should be kicking in to balance it within that range. So as long as you know that you did not eat anything, you can have water, but don't eat any food. It should be stabilized there. If it's higher and blood glucose levels exceed about 100 to 185 milligrams per deciliter, that is the maximum. That is the threshold of the proximal convoluted tubule's ability to absorb 100% of the glucose. All right, so as long as your glucose levels are normal, as the glucose gets through the glomerulus, the glomerular capillaries, and becomes filtrate, enters the PCD. And we said, the glucose and amino acids, if they're abnormal levels in the bloodstream, you will be able to absorb 100% of those because your body wants to use glucose and amino acids for other things, right? But if you have higher than normal glucose levels, that PCT can only absorb so much. I mean, it's of a certain diameter with villi, and it's only so long, and it will absorb as much as it can. Right? But after that, the glucose stays in the filtrate and passes to the descending loop of Henle, ascending loop of Henle, and so forth. Well, do you recall seeing any other area of the nephron that is capable of absorbing glucose? No, no. It gets absorbed at the PCT, or it doesn't get absorbed at all. All right, so knowing that, now you understand why testing urine, having that as a very quick screen for diabetes, can be helpful. That things that are in excess, that are not being absorbed, properly along the pathway of the tubular system of a nephron, if they're higher than normal, they exceed certain levels, or capabilities of parts of those nephrons, it spills over into the urine. So the urine is a very easy place to test to see whether the levels are normal or abnormal for all kinds of different things that are capable of being found in urine. Even though they might not be normally found there, you can test for glucose, amino acids, ketones, bilirubin, the pH of the urine, the concentration, of urine. We're going to talk about what that means. Right? So things that are in excess gives you good, things in excess will spill over. When you test it with a urinalysis strip, there are often a degree of changes, color changes that can occur as the levels increase, and then you match it to the side of the bottle, just like you would when you measure pH. You use your litmus paper and you test the fluid, and you match it to the color on the side of the bottle that will tell you what pH value it is because colors match up. And it's the same concept. Okay, so this is important. That's why, when you have too much glucose, right, it's going to spill over. And it not only spills over in the kidneys, you'll study more about diabetes 1 and diabetes 2 when you get into your programs. But, if it's spilling over there, it's spilling over the interstitial spaces and other areas of the body, the retina of the eye, other areas that are very susceptible, to having excess glucose in the environment for long periods of time, it can change their function and damage them, like the retinas of the eye. Okay, that takes us to urinalysis. Urinalysis is a test that evaluates a sample of urine. Urinalysis is used to detect and assess a wide range of disorders, such as urinary tract infections, kidney disease, and diabetes. It can also be used to test for illegal substances. Oh. All right. So urinalysis involves examining the appearance, the concentration, and the content of urine. Abnormal urinalysis results may point to a disease or illness. For example, urinary tract infection can make urine look very cloudy instead of clear. Increased levels of protein in urine can be a sign of kidney disease, which it often is, especially elevated levels. All right, so sometimes one particular analyte, we call it, found there will give you a good indication of disorder, like elevated glucose. However, it still takes looking at all these different results that you get from urinalysis and then follow up generally with a blood draw to do a chemistry panel on their circulating blood to put it all together. But some things, when results that you find from the urinalysis give you a very, very strong indication. As a combination of those things come up, is that whether, and your patient history, of course, is whether the glucose is there because maybe they have diabetes, maybe they have gestational diabetes, like maybe you have a pregnant woman, getting toward midway through her pregnancy, toward the last trimester, and now you're getting glucose, but you're also maybe getting a little bit of protein, a couple other things in there. You have to look at the whole picture. Abnormal results of urinalysis often require more testing and evaluation to uncover the source of the problem. And I will tell you, that's usually what happens. You can always have a patient come back in a few days and pee in a cup again, grab another specimen and run it again to see if you get, similar results. In medicine, a symptom is generally subjective while a sign is objective. Yeah, and the reason why I say that is because in some of the books that the different lab instructors may use, sometimes those terms are used interchangeably, and it's not. And it's good to start getting used to that, because a symptom is something that the person kind of feels, subjective for your patient. I feel pain. I've had headaches. I feel hot. I feel cold. That's subjective. A sign is something that you find, like when you take their blood pressure. The sign of elevated blood pressure is, maybe the 160 over, 105 millimeter of mercury blood pressure. That's objective. Pupillary responses when you're doing a physical exam. An objective is doing your cranial nerve tests on a patient and obtaining results. Things like that. X-rays, the results of blood work, the results of urinalysis, they're all objective. Also, another word for cause or origin of a condition is called etiology. Okay, so urinalysis, although many analytes can be evaluated upon urinalysis, we will be looking at only a few. And one of them that's important to keep in mind is specific gravity. Specific gravity is essentially measuring the concentration of the urine. Is a measure of the concentrate of solutes in the urine. Solutes to the water, the solvent. It measures the ratio of urine density compared to plain water or deionized water, and provides information on the kidney's ability to concentrate urine. So a urinary specific gravity measurement is a routine part of your urinalysis. The normal reference range is 1.005 to 1.030. The test range, the results can go a little higher than that and lower than that, but the normal range is 1.005 to 1.030. It's comparing it to water that is 1.00000. It's just one. So we should always have some solute in the urine that we're producing. There's got to be something as blood's passing through there, waste products that need to be eliminated and put into urine. When you have concentrated urine, which means you've reabsorbed a lot of water, then you'll have a high specific gravity, closer to 1.030 to 1.035, maybe even a little bit higher. Very, very concentrated. If it's very dilute urine, high urine output, then it's going to be closer to 1. It'll be closer to 1.005. It might even be less than that, 1.001 or 2. If you have diabetes insipidus, which is a condition that you don't produce enough antidiuretic hormone, which means you're not concentrating your urine, then you will have specific gravities that are very, very close to 1.000. It'll be less than 1.005. Okay, so what are some terms? Glucose in the urine is called glucosuria. That's just the presence of glucose in urine. When we have ketones in urine, we call it ketonuria. When there are proteins in urine, referred to as proteinuria. And when we have erythrocytes or red blood cells, blood in urine, called hematuria. All right, so this is a chart that kind of gives you some, the name of the condition and possible causes of glucose in urine. So it could be diabetes mellitus. It could be, unusual pregnancy. Proteins called proteinuria, maybe even albuminuria. Non-pathological excessive physical exertion, pregnancy, glomerulonephritis, severe hypertension, heart failure. They're often the sign of proteinuria or protein in the urine consistently is generally a sign of a failing renal system. Okay, ketones, maybe excessive formation, accumulation of ketone bodies, as in starvation or maybe untreated diabetes mellitus. We talked about this in metabolism. We said that the burning of fats when you're not burning glucose appropriately, because you either don't produce insulin or you have insulin receptor resistance on cells, you start burning the fats, and the fats, by converting a lot of those fatty acid tails, produces ketone bodies, and this ketoacidosis. Hemoglobin, maybe a transfusion reaction, hemolytic anemia, severe burns, bile pigments, bilirubin, maybe some liver disease, hepatitis, cirrhosis, or obstruction of bile ducts from the liver to the gallbladder causes the bilirubin to back up into the bloodstream and then overflow into urine when you test it. Hematuria, bleeding away along the urinary tract due to either trauma, kidney stones, infection, cancer, somewhere where you have red blood cells either getting through broken or damaged parts of a nephron, or generally it's in the glomerular capillaries themselves. Or maybe even leukocytes. All right, that condition is called pyuria, pus in urine. You have some kind of urinary tract infection. There are other indicators of that as well, right? There's different leukocyte esterase, identifies the presence of active white blood cells, and nitrites, backtrass nitrates, are generally indicative of bacteria residing in an area for a while and releasing some of their waste products. Okay, so that is the end of the urinary system.